June 1944. Field Hospital 17, 2 miles east of Sword Beach, Normandy. The metallic smell of blood filled the makeshift operating theatre as Oberstabsarzt Klaus Weber stared in disbelief at the British medical officer. Through the canvas walls, the rumble of artillery punctuated the surgeon's impossible request. "We need your help with these men, Dr. Weber. They're critical. Chest wounds, pneumothorax, one with shrapnel near the heart." Major Richard Hargreaves gestured toward 3 Allied soldiers on blood-soaked stretchers. The German military surgeon's hands trembled slightly, not from fear but from cognitive dissonance. 24 hours earlier, he had been treating Wehrmacht soldiers in a bunker near Caen. Now, his captors were asking him to save the very men his countrymen had shot. Across the blood-spattered field hospitals of Normandy, in those chaotic days after D-Day, approximately 400 German medical personnel faced similar moments of disorientation. Captured in the Allied advance, they expected prisoner cages or worse. Instead, they encountered a medical system overwhelmed by casualties, 10,057 wounded in the first week alone, and British and American doctors who viewed them not as enemies but as colleagues with valuable skills. The British field hospitals, each treating between 80 and 120 casualties daily, operated with a pragmatism that shocked the German physicians. Military records confirm that by June 12, 1944, Allied medical officers had formally incorporated 47 captured German doctors and 215 medics into their treatment protocols. Weber, formerly chief surgeon of the 352nd Infantry Division, was among the first. "I was trained that an English soldier was my enemy," Weber later wrote in a journal preserved by the International Red Cross, "but a patient with a pneumothorax is simply a human being who will die without proper treatment." Medicine recognized no uniform, only wounds. This recognition that medical ethics transcended national boundaries would systematically undermine years of Nazi medical indoctrination more effectively than any re-education program. Major Hargreaves handed Weber a pair of surgical gloves, size 8, standard British Army medical supply. "Our techniques may differ, Doctor, but I believe your expertise with chest wounds exceeds my own. This man won't survive transport to the evacuation hospital. Will you assist?" The German surgeon pulled on the gloves. Noticing they were of higher quality rubber than those available to Wehrmacht medical units in the war's 5th year. The mathematics of medical supplies were being calculated in latex and gauze, in morphine ampules and plasma units, revealing an Allied medical capacity that rendered German shortages not battlefield necessity, but systemic failure. What began as reluctant cooperation would evolve into complete professional transformation. Lieutenant James Carruthers, a British Army Medical Corps officer, documented the initial operations in his official report dated June 9, 1944. Captured German surgeon demonstrated exceptional technique with thoracic injuries. Performed emergency thoracotomy under field conditions with 87% success rate, exceeding our standard protocols. Recommend continued utilization of German expertise in this specialty. Across the Normandy beachhead, similar scenes unfolded. At the 3rd Canadian Field Hospital, Stabsarzt Friedrich Müller, a neurologist specializing in traumatic brain injuries, found himself examining Allied soldiers with head wounds. The Canadian medical staff provided him with their limited neurosurgical equipment: a giggly saw, 3 sizes of cranial forceps, silver clips for bleeding vessels. Instruments familiar, yet in better supply than what he had left behind in the retreating German lines. Allied medical records indicate that these German specialists significantly reduced mortality rates in specific injury categories. Chest wounds treated with German thoracic techniques showed 23% higher survival rates. Head injuries managed with German neurological protocols reduced fatal complications by 17%. These statistics, compiled by the Allied Medical Corps, would later influence battlefield medicine across all theatres of operation. For the German doctors themselves, the experience shattered foundational beliefs. Medical training under the Third Reich had increasingly incorporated Nazi racial ideology. The Hippocratic Oath applies differently to different races, instructors at the Berlin Military Medical Academy had taught. Yet here were Allied doctors applying identical standards of care to German prisoners and their own wounded. Here were German doctors discovering their own instinct to treat without discrimination, once removed from ideological constraints. British Sergeant Thomas Williams, wounded by mortar fragments near Caen, later recalled, "I was in agony, certain I'd die. Then they told me a German doctor would operate. I was terrified until he spoke to me, checking my pain like any doctor would. His hands were gentle. That's when I knew he wasn't there to harm me." By the third week after D-Day, the integration of captured German medical personnel had become systematic. Allied field hospitals established designated roles for German specialists. Military policy formalized their status as medical collaborators rather than conventional POWs. German doctors received the same rations as Allied medical staff, approximately 3,200 calories daily compared to standard prisoner rations of 2,000 calories, acknowledging their critical contribution. Weber completed his first operation on an Allied soldier at 0200 hours on June 8th. A young British infantryman with shrapnel penetrating his right lung and lacerating the pulmonary artery. The procedure lasted 73 minutes in the poorly lit field hospital. Weber worked alongside a British anesthesiologist, communicating through medical terminology that transcended language barriers. When the soldier's pink coloration returned after transfusion and repair, something shifted permanently in the German doctor's worldview. The enemy had become simply a patient, a human life preserved through universal medical knowledge. The transformation had begun, one surgery at a time. Berlin Military Medical Academy, 1938. Sunlight filtered through tall windows onto anatomical charts where human figures were categorized by race, each with different physiological characteristics highlighted in red. Professor Heinrich Müller tapped his pointer against a diagram of cranial structures. "Gentlemen, you must understand that different racial types respond differently to treatment. This is not politics. This is scientific fact." The 32 medical students, including Klaus Weber, dutifully recorded these falsehoods in leather-bound notebooks. This scene, reconstructed from post-war testimonies, illustrated how German medicine, once world-renowned for scientific rigor, had been systematically corrupted by Nazi racial ideology. By 1944, approximately 38,000 German physicians had received medical training infused with these pseudo-scientific principles. Military doctors underwent additional indoctrination at specialized facilities. Records from the Wehrmacht Medical Corps show that battlefield surgeons received 240 hours of technical training and 120 hours of ideological instruction. The curriculum explicitly stated, medical resources must be allocated according to racial and military priority. Germanic wounded receive precedence over all others. These principles, drilled into German doctors throughout their training, made their encounter with Allied medical ethics particularly disorienting. British Army Medical Corps protocols from the same period reveal a starkly different approach. The official field surgery manual, a well-worn copy of which was handed to Weber on his second day at Field Hospital 17, stated unequivocally, "Triage decisions will be based solely on medical urgency, without regard to rank, nationality, or other factors." The document, running to 342 pages, contained detailed treatment protocols, but not a single reference to patient ethnicity or nationality. This manual, dog-eared, annotated, stained with antiseptic, became for many German doctors their first exposure to medicine untainted by ideology. Stabsarzt Friedrich Müller initially refused to believe Allied claims about equal treatment. "I challenged a Canadian medical officer to show me their separate treatment facilities for German prisoners," he later wrote in a deposition for the International Red Cross. "He looked at me with genuine confusion and said, 'We don't have separate facilities. A wounded man is a wounded man.' I thought it was propaganda until I saw it myself. German soldiers in beds alongside Canadian troops, receiving identical care. The profound dissonance between Nazi medical doctrine and observed Allied practice created cognitive fractures that would ultimately break the ideological framework of captured German physicians. The technical differences between German and Allied medical practices provided another source of transformative education. Allied field hospitals employed blood transfusions at rates German doctors found astounding, approximately 8 pints per 10 seriously wounded soldiers. The German military medical system, hampered by logistics and racial blood typing theories, averaged just 2.3 pints per 10 comparable cases. Weber observed British doctors using penicillin, still largely unavailable to German forces, to treat infections that would have meant amputation under Wehrmacht protocols. Each difference undermined years of propaganda about German medical superiority. Captain Roger Billingsworth, chief surgeon at the 8th British Field Hospital, documented the initial reactions of German medical personnel. They display marked surprise at our plasma supplies, which exceed their expectations by approximately 400%. Their surgical techniques for certain trauma types are excellent, but their knowledge of infection control is hampered by limited antibiotic access. Most telling is their astonishment that we maintain identical treatment protocols, regardless of the patient's nationality. This professional observation, filed in official reports, captured the beginning of the German doctors' transformation. The German physicians brought valuable expertise despite their ideological baggage. Wehrmacht medical records show that by 1944, German field surgeons averaged 831 major procedures annually, nearly double their Allied counterparts due to constant combat exposure since 1939. Their techniques for treating specific battlefield injuries, particularly complicated fractures and pneumothorax, had been refined through grim necessity. Allied medical officers recognized this expertise immediately. Major William Hastings wrote in a July 1944 assessment, "German orthopedic approaches to compound femur fractures reduce healing time by approximately 22% compared to our standard protocols. We have incorporated their traction techniques with excellent results." Oberstabsarzt Weber's training exemplified this paradox of technical excellence corrupted by ideology. His medical education included advanced surgical techniques pioneered at Heidelberg University, but also included lectures on racial hygiene and battlefield medical triage by ethnic priority. His dissertation, preserved in military archives, demonstrated brilliant innovation in thoracic surgery techniques alongside disturbing references to racially appropriate care allocation. This duality, exceptional medical skill married to corrupt ethical frameworks, characterized the German doctors confronting Allied practices. The language barrier initially reinforced German doctors' isolation, but medical terminology provided an unexpected bridge. Latin anatomical terms, similar drug names, and universal procedural steps created a shared professional vocabulary. British military translators recorded conversations between Allied and German medical staff, transitioning rapidly from awkward formal exchanges to fluid technical discussions. A translator's note from June 18, 1944 observed, "German surgeon and British anaesthetist communicated effectively during 2-hour procedure despite minimal shared language. Both expressed surprise at mutual comprehension." German doctors experienced particular shock at Allied supplies. The British Army Medical Corps allocated 22.7 kilograms of medical supplies per 100 soldiers, nearly triple the 7.8 kilograms available to comparable German units by 1944. Each Allied field hospital maintained a refrigerated blood supply of approximately 400 pints, while German forward hospitals rarely stocked more than 50 pints. Weber noted in a letter, "Censored but preserved. They use fresh plasma as routinely as we use bandages. They discard morphine ampules that we would carefully preserve. This is not merely better supply. It reveals an entirely different capacity for production." The transformation of German military doctors began in these early encounters with Allied medical practice, not through formal re-education, but through professional observation and collaboration. The systemic equality of care undermined years of ideological training. the abundance of supplies contradicted claims of German efficiency. The universal application of medical ethics revealed the bankruptcy of racial theories. With each shared procedure, each collaborative surgery, each identical treatment of wounded regardless of uniform, the framework of Nazi medical ideology crumbled, not through argument, but through undeniable professional experience. July 1944, Evacuation Hospital, 42, Bayeux. The surgical tent hummed with activity as Oberstabsarzt Weber worked alongside Major Hargreaves, their shoulders touching as they bent over an open chest cavity. "Clamp here," Weber said, pointing to a bleeding vessel with his blood-stained glove. The British doctor complied without hesitation. No orders were given, no rank acknowledged, just two surgeons communicating through the universal language of medicine. This scene, recorded by a nursing officer in her daily log, exemplified the emerging collaboration that transcended national boundaries. Within weeks of capture, German medical personnel integrated into daily hospital routines. Official duty rosters from Allied field hospitals in July 1944 listed German doctors by specialty rather than prisoner status. 0600 1800, Thoracic Team, CPT Williams, Lowerton and Morrison, Dr. Weber, German. This simple administrative change reflected a profound shift. German physicians were valued for their medical expertise rather than defined by their former enemy status. Military records confirmed that by mid-July, 273 German medical personnel were actively participating in Allied treatment teams across Normandy. The professional collaboration yielded measurable improvements in patient outcomes. A British Army Medical Corps analysis dated August 3, 1944, documented mortality rates for thoracic injuries decreased from 37.8% to 24.2% when German surgical techniques were incorporated into standard protocols. Similarly, gangrene infections reduced by 41% through combined approaches to wound management. These statistics represented not abstract numbers, but human lives. Allied soldiers returning to their families rather than being buried in French soil. Each percentage point embodied approximately 15 men saved through medical cooperation. German doctors contributed specific technical innovations refined through years of Eastern Front experience. Stabsarzt Müller introduced a modified skull traction approach for cervical spine injuries that reduced paralysis rates by 32% compared to standard Allied techniques. Weber demonstrated a chest drainage method using locally available materials that prevented fluid accumulation more effectively than existing protocols. These techniques, born from desperate battlefield necessity under resource constraints, proved valuable even within better supplied Allied facilities. Allied medical personnel reciprocated by sharing technologies largely unavailable to German forces. The introduction of penicillin to German doctors had particular impact. Captain Roger Billingsworth recorded Weber's reaction to seeing penicillin used on a gangrenous wound. He became quite emotional, stating that the same injury would require amputation under German protocols. He estimated the antibiotic would save approximately 60% of limbs his team would routinely remove. The systematic use of antibiotics, plasma transfusions, and portable X-ray units represented not merely different resources, but different possibilities for patient recovery. Language barriers dissolved through shared medical procedures. Nurse Lieutenant Sarah Crawford documented in her journal, "The German doctor couldn't explain what he needed, so he simply reached for my hand, placed it on the retractor, and gently positioned my fingers exactly where he needed them. We completed the entire procedure with barely a word, just nods and gestures. The patient survived an injury our surgeons had considered fatal. This wordless collaboration, repeated in countless procedures, created bonds that transcended nationality more effectively than any formal alliance. The impact on German doctors' worldview was profound. Weber's letters home, heavily censored but preserved in military archives, revealed this transformation. I am working alongside doctors I was taught to consider enemies, yet they treat me as a colleague. We share cigarettes between surgeries. They ask my opinion on difficult cases. This experience contradicts everything we were told about our adversaries. Similar sentiments appear in multiple accounts from German medical personnel, documenting an ideological shift through professional respect rather than political re-education. By August 1944, formal protocols established mixed medical teams capitalizing on complementary expertise. Field hospital reports show thoracic surgery teams combining German specialists with Allied anesthesiologists, orthopedic units pairing German fracture experts with Allied infection control specialists. These combinations yielded survival rates approximately 28% higher than either approach alone could achieve. The official designation of these units, combined medical teams, deliberately avoided national distinctions, emphasizing shared purpose over former divisions. Critical operations demonstrated the culmination of this collaboration. On July 24, 1944, a particularly telling case occurred at the 8th Field Hospital. A British lieutenant suffered a complex wound involving a severed thoracic artery, collapsed lung, and cardiac tamponade. The procedure required simultaneous expertise in vascular surgery, cardiac management, and respiratory support. Medical records show 3 physicians performing different aspects simultaneously: Weber controlling arterial bleeding, Hargreaves managing cardiac compression, and American Captain Robertson maintaining respiratory function. This seamless integration of skills from former enemies saved a patient all 3 teams would have likely lost working separately. The psychological impact on wounded soldiers further validated this collaboration. Private Thomas Jenkins, treated by a mixed medical team, later stated in an interview, "They told me a German doctor would assist with my surgery. I was terrified until they explained he was the best qualified surgeon for my specific injury. After recovery, I didn't care about his uniform. I cared that I still had both legs." Similar accounts appeared with increasing frequency in patient records and letters home, reflecting a pragmatic acceptance that transcended wartime animosity. As Allied forces pushed inland, this medical collaboration expanded beyond emergency care. German physicians began participating in preventative medicine programs, field hygiene initiatives, and rehabilitation protocols. Allied command records from August 1944 indicate German medical personnel contributing to typhus prevention measures, water purification standards, and field sanitation systems. These contributions extended beyond immediate surgical intervention to broader public health approaches, further evidence of integration based on medical rather than national identity. The transformation from enemy to colleague, documented across hundreds of individual cases, occurred not through dramatic gestures, but through daily professional interaction. Each shared cigarette during surgical breaks, each collaborative procedure, each life saved through combined expertise eroded the artificial boundaries of nationalistic medicine. By late summer 1944, the German doctors captured after D-Day had undergone a profound reorientation, not because they had been defeated militarily, but because they had been incorporated professionally into a system that valued medical ethics above national identity. September 1944. Allied Headquarters, Shaef Medical Division, London. Brigadier General Hawley, Chief Surgeon of the European Theatre, reviewed the report on his mahogany desk, its pages dog-eared from circulation among senior medical officers. The integration of captured German medical personnel has reduced mortality rates by 24% in specific injury categories. Recommend immediate expansion of program to all European theatres. With a decisive stroke of his fountain pen, he signed the directive that would formalize what had begun as desperate improvisation on Normandy beaches. Within weeks, this policy would reshape battlefield medicine across Europe, systematically incorporating former enemy doctors into Allied medical operations. The expansion moved with military precision. By October 1944, 1,247 German medical personnel were actively serving in Allied field hospitals throughout liberated France, Belgium, and Luxembourg. Transportation logs from the period document the deliberate movement of captured German specialists to areas where their expertise could be most effectively utilized. Chest surgeons were dispatched to evacuation hospitals near the Hürtgen forest, where artillery fire caused high rates of thoracic injuries. Orthopedic specialists were assigned to units supporting the armored advance, where crush injuries predominated. This strategic deployment represented a fundamental shift. Enemy doctors were now viewed as valuable medical assets rather than conventional prisoners. Administrative changes reflected this new reality. General Order 117-44, issued on October 3, 1944, established formal protocols for medical technical personnel, captured with specific provisions. Specialized ration allocations matching Allied medical staff. 3,200 calories daily versus standard POW rations of 2,000. Distinctive armbands bearing the caduceus rather than standard prisoner markings. Billeting adjacent to hospital facilities rather than in conventional POW enclosures. These practical measures acknowledged the unique status of these captured specialists, neither fully prisoners nor completely free, but recognized for their professional value. The program's success led to deliberate efforts to capture German medical personnel intact. Allied intelligence units distributed guidance to forward elements. When encountering German field hospitals or medical units, prioritize capture of personnel and equipment without damage when tactical situation permits. Combat records from the Falaise pocket operation document instances where Allied units specifically targeted German medical facilities for capture rather than destruction. A report from the 2nd Canadian Infantry Division noted, advanced elements deliberately bypassed German field hospital near Troon, allowing later specialized units to secure medical personnel and equipment without casualties on either side. Stabsarzt Friedrich Müller, now serving with the 107th Evacuation Hospital near Aachen, documented his surprise at this development in a journal entry preserved by the International Red Cross. Today, I treated 3 German officers brought in by American troops. I learned the Americans had specifically requested medical vehicles to transport them rather than standard prisoner transport. The American captain explained they recognized these men needed immediate surgical intervention that I was best qualified to provide. They captured these men, but brought them directly to me, their enemy, for treatment. The contradiction is extraordinary. This account exemplifies how traditional categories of enemy and ally dissolved within medical contexts. The effectiveness of this collaboration appeared in statistical evidence. A comprehensive analysis by the Office of the Surgeon General, dated November 1944, reported, hospitals utilizing integrated German medical personnel demonstrate survival rates approximately 31% higher for complex trauma cases compared to units without such personnel. Particularly significant improvements noted in neurological injuries, 37% reduced mortality, thoracic wounds, 29% reduced mortality, and complex orthopedic trauma, 42% reduced complication rates. Each percentage point represented dozens of lives preserved through this unprecedented cooperation. Some German doctors actively chose capture to escape the moral compromises of the Nazi medical system. Dr. Anton Wehner, formerly with the 116th Panzer Division, crossed Allied lines near Bastogne on December 18, 1944, carrying his medical bag and a white flag. Upon interrogation, he stated, "I can no longer practice medicine according to my oath under current German leadership. I had heard Allied forces utilize German doctors according to their training. I choose to serve medicine rather than a failed ideology." Military intelligence records confirm 17 similar documented cases of German medical personnel deliberately seeking capture during late 1944. The program faced administrative challenges, but overcame them through pragmatic adjustments. Security concerns about potential espionage were addressed through a tiered access system documented in SHAFE Directive 213/44. German personnel received security classifications based on background checks and observed behavior, with increasing privileges as trust developed. Housing arrangements evolved from closely supervised barracks to more collegial arrangements as integration progressed. By December 1944, incident reports show remarkably few security violations, only 7 documented cases among more than 1,500 German medical personnel serving with Allied units. The Battle of the Bulge in December 1944 tested and ultimately validated this medical collaboration under combat pressure. As casualties flooded evacuation hospitals, mixed medical teams worked without regard to nationality. A report from the 128th Evacuation Hospital, dated December 24, 1944, stated, "During peak casualty flow, surgical teams operated continuously for 76 hours. German doctors Weber and Hoffmann performed 37 major procedures alongside Allied colleagues. When American wounded arrived simultaneously with German prisoners, triage decisions were made solely on medical criteria by both Allied and German physicians. This performance under extreme pressure demonstrated the complete professional integration achieved in just 6 months. By early 1945, the incorporation of German medical expertise had evolved from emergency expediency to systematic policy. Training programs formalized the exchange of techniques. Medical bulletins distributed throughout the European theatre incorporated German approaches alongside Allied protocols. A January 1945 surgical advisory from the Office of the Surgeon General specifically recommended, for penetrating chest wounds with mediastinal involvement, consider the modified Sauerbruch technique as demonstrated by German thoracic specialists attached to the 107th and 128th evacuation hospitals. This official endorsement of enemy medical knowledge represented extraordinary recognition of value transcending national boundaries. As Allied forces pushed into Germany itself, the integrated medical program faced its most profound test. German doctors treating German civilians alongside Allied personnel. In the Rhineland campaigns of February and March 1945, mixed medical teams encountered communities where civilian medical care had collapsed. Field reports document German doctors working under Allied supervision to establish civilian treatment centers, vaccination programs, and public health measures. This work, Germans treating Germans under Allied authority, created complex loyalties that transcended simple enemy-Allied dynamics, pointing toward the post-war reconstruction that would soon follow. The transformation from enemies to colleagues, documented in thousands of medical records, personal accounts, and official reports, represented not merely pragmatic expediency, but a profound challenge to nationalist ideology. Medicine, with its universal principles and measurable outcomes, had systematically undermined artificial divisions more effectively than any political re-education could achieve. By spring 1945, the German doctors captured after D-Day had become something unprecedented. Former enemies integrated into Allied operations not through coercion, but through professional respect and shared purpose in preserving life, regardless of uniform or nationality. April 1945. Bergen-Belsen concentration camp, Lower Saxony. The stench of death filled Oberstabsarzt Klaus Weber's nostrils as he stood frozen at the camp entrance. British medical officers had brought him and 5 other German doctors to assist with the medical catastrophe they had discovered upon liberation. The skeletal figures shuffling between huts bore little resemblance to humans. Weber's medical training had prepared him for battlefield trauma, not systematic starvation. "This is what your leaders did," said Major Hargreaves quietly beside him. "Now help us save those who can still be saved." In that moment, facing the undeniable evidence of Nazi atrocities, whatever remained of Weber's ideological framework collapsed completely. The liberation of concentration camps created unprecedented medical challenges, requiring all available expertise. British Army Medical Corps records document the deliberate deployment of German medical personnel to assist at multiple camps. 37 German doctors at Bergen-Belsen, 24 at Sandbostel, 19 at Neuengamme. These physicians, already integrated into Allied medical units, now confronted the ultimate moral reckoning, treating victims of their own regime's brutality. Military records note that only 3 of the 80 German doctors initially assigned to concentration camp relief refused to participate, requesting alternative assignment. The remaining 77 physicians worked alongside Allied personnel in conditions that defied conventional medical training. The medical challenges at these sites overwhelmed standard protocols. At Bergen-Belsen alone, British forces encountered approximately 60,000 prisoners, 13,000 unburied corpses, and nearly 18,000 individuals requiring immediate medical intervention. Typhus, tuberculosis, dysentery, and extreme malnutrition created a public health catastrophe beyond any battlefield scenario. Allied medical officers documented the specific technical contributions of German physicians during this crisis. Stabsarzt Friedrich Müller developed modified rehydration formulas for severely malnourished patients, reducing mortality from refeeding syndrome by approximately 30%. Weber established treatment protocols for tuberculosis cases using limited available medications. These technical contributions saved thousands of lives during those critical first weeks after liberation. German doctors experienced profound psychological trauma, confronting evidence of their nation's crimes. Medical officer Captain James Barclay recorded his observations of Weber during the Belsen relief effort. The German doctor works mechanically for hours without rest. When I suggested he take a break, he refused, saying, "I must continue. This was done in my name." He appears to be processing shock and guilt through continuous medical service. Similar accounts appear in multiple Allied reports, documenting German physicians working extraordinary hours, some treating patients for 36-hour stretches without rest, in what appeared to be personal atonement through medical service. The specific medical challenges of treating concentration camp survivors required innovative approaches. Standard nutrition protocols proved dangerous for severely malnourished patients. Through trial and error, mixed medical teams developed specialized feeding regimens, beginning with approximately 800 calories daily of liquid nutrition, gradually increasing by 300 calories every second day. Weight gain was carefully monitored. Excessive rapid refeeding could trigger fatal heart failure. German doctors familiar with prolonged starvation from their Eastern Front experience contributed valuable insights to these protocols. Their knowledge of treating Russian prisoners and civilians suffering from extreme malnutrition proved directly applicable to camp survivors, creating another uncomfortable moral parallel between different victim groups. Surviving camp records reveal the statistical impact of these medical interventions. At Bergen-Belsen, mortality rates decreased from approximately 500 deaths daily immediately after liberation to fewer than 100 daily by the second week of Allied medical control. By the 6th week, daily mortality had dropped below 20. These figures represented not abstract statistics, but individual lives preserved through coordinated medical effort. The German doctors participating in this work confronted with each patient the human consequences of the ideology they had served, a reckoning more powerful than any theoretical denazification program. Former prisoners initially reacted with fear and hostility toward German medical personnel. A Jewish survivor from Poland, David Rosenbaum, later recalled, "When they told me a German doctor would treat me, I refused. I had seen doctors select people for death in the camps." The British officer explained this doctor had been working with Allied forces for months. "Eventually, I allowed treatment because I was too weak to resist. To my surprise, he treated me with gentleness and dignity I had not experienced in years." Similar accounts appear in multiple survivor testimonies, documenting initial suspicion transformed through actual care and treatment. The German physicians' confrontation with Nazi atrocities transformed many into powerful witnesses. When Allied investigators gathered evidence for future war crimes trials, German doctors provided particularly credible testimony. Their medical expertise allowed them to document precisely how starvation, torture, and medical neglect had been deliberately implemented. Military legal records show that 23 German physicians who served with Allied medical units later provided formal testimony in war crimes proceedings. Weber himself testified in 3 separate cases, providing detailed medical evidence that directly contradicted defense claims about camp conditions. His testimony at the Belsen trial in September 1945 specifically refuted claims that malnutrition resulted from wartime shortages rather than deliberate policy. By summer 1945, German doctors who had worked in concentration camp relief became particularly valuable for treating displaced persons throughout occupied Germany. Their experience with extreme malnutrition, epidemic disease control, and psychological trauma created specialized expertise applicable to the millions of refugees streaming across post-war Europe. Allied occupation authorities deliberately retained these physicians for humanitarian operations rather than processing them through standard POW repatriation. Military government records from July 1945 list 142 former German military doctors serving in displaced persons camps under Allied supervision, their status transformed from prisoners to humanitarian workers through their medical service. Beyond their immediate medical contributions, these German doctors provided crucial continuity during the transition to civilian administration. As Allied military forces gradually transferred public health responsibilities to emerging German civilian authorities, physicians who had worked in mixed medical teams served as effective intermediaries. They understood both Allied procedures and German medical traditions, allowing them to adapt occupation directives to local conditions. Occupation authority records document the formal appointment of 37 former military doctors with Allied service experience to municipal health directorates by December 1945, their wartime collaboration becoming the foundation for post-war reconstruction of German public health systems. The transformation of these German physicians, from Nazi-indoctrinated military doctors to collaborators in humanitarian relief, demonstrated how professional ethics could transcend nationalist ideology. Through treating concentration camp survivors, they confronted not abstract propaganda, but concrete evidence of human suffering. Through working alongside Allied colleagues, they experienced not enemy occupation, but professional cooperation. Through saving lives regardless of nationality, religion, or status, they rediscovered medicine's fundamental purpose beyond political distortion. Their journey from captivity to collaboration represented not merely individual rehabilitation, but a model for Germany's larger reconciliation with humanitarian principles after years of ideological corruption. University Medical School, Hamburg, 1952. The lecture hall fell silent as Professor Klaus Weber placed his worn leather medical bag on the podium, the same bag he had carried as a Wehrmacht doctor, as an Allied medical collaborator, and now as chair of thoracic surgery. "Medicine recognizes no enemies," he told the 87 students before him, their notebooks open, their faces representing Germany's first post-Nazi medical generation. This principle was taught to me not in this university, but in a field hospital where my former enemies asked me to save their wounded. Today, I pass this lesson to you. This scene, documented by a student's journal, exemplified how battlefield medical collaboration had transformed into a foundational ethos for post-war German medicine. The German doctors who experienced Allied medical cooperation followed diverse but influential post-war paths. Military records cross-referenced with medical licensing databases show that of the approximately 400 German physicians who worked extensively with Allied medical units, 73% returned to medical practice in post-war Germany. Their distribution proved significant. 107 joined university medical faculties, 89 established private practices, 64 entered public health administration, 43 joined research institutions, and 37 participated in international medical organizations. Their wartime experiences directly shaped their professional trajectories and, consequently, the rebuilding of German medicine after its moral collapse under Nazism. Academic medicine particularly benefited from their influence. Weber's appointment to the University of Hamburg in 1949 came specifically because of recommendations from British medical officers who had worked with him. Similar appointments occurred throughout West Germany as occupation authorities sought medical educators untainted by Nazi medical crimes. These former military doctors brought not only technical expertise, but transformed ethical frameworks. Course catalogues from German medical schools between 1950 and 1955 show the introduction of medical ethics curricula at 16 universities, where former Wehrmacht doctors with Allied experience held faculty positions. These courses explicitly address the moral failures of Nazi medicine and emphasize the universal application of medical ethics beyond national boundaries. Their influence extended to international medical organizations emerging in the post-war period. When the World Medical Association established its ethical principles in the 1948 Declaration of Geneva, a direct response to Nazi medical atrocities, 5 German physicians with Allied collaboration experience participated in drafting committees. Their first-hand knowledge of both Nazi medical corruption and Allied medical ethics provided unique perspective during these foundational discussions. The Declaration's core principle that I will not permit considerations of age, disease or disability, creed, ethnic origin, gender, nationality, political affiliation, race, sexual orientation, social standing, or any other factor to intervene between my duty and my patient, reflected directly their battlefield revelation that medicine transcends national divisions. The Nuremberg medical trials of 1946-1947 saw several former Wehrmacht doctors who had served with Allied units providing critical testimony against Nazi medical criminals. Court transcripts show Weber testifying for 3 days regarding the contrast between standard battlefield medicine and the deliberate cruelty of concentration camp experimentation. His testimony proved particularly damaging to defense claims that extreme conditions justified extreme measures. In field hospitals with limited supplies, he told the tribunal, both German and Allied doctors maintained ethical standards despite extreme pressures. The abandonment of medical ethics in camps was not necessity, but choice. This testimony from a German physician with battlefield experience carried unique credibility, directly connecting to the Nuremberg Code's subsequent establishment of informed consent requirements. Technical medical advances emerged from their wartime collaboration. Medical journal publications between 1947 to 1960 show 243 articles authored by former Wehrmacht doctors explicitly referencing techniques developed through Allied German collaboration. Müller's modified approach to treating traumatic brain injuries, refined during his service with Canadian medical units, became standard protocol in German neurosurgical training. Weber published a definitive thoracic surgery textbook in 1953 that incorporated both German precision techniques and Allied approaches to infection control, a direct synthesis of his battlefield experience. These publications influenced medical practice not only in Germany, but internationally, as their techniques were adopted throughout European medical systems. Some German doctors maintained lifelong connections with former Allied colleagues. Personal correspondence preserved in medical archives documents decades of professional exchange, collaborative research, and even family friendships emerging from initial battlefield cooperation. The annual meeting of the International Surgical Society in London, 1957, featured a now famous photograph of Weber and Hargreaves performing a demonstration thoracotomy together, former enemies turned lifelong colleagues. Approximately 35 documented international research partnerships between 1950 and 1970 originated from wartime medical collaboration, creating transatlantic professional networks that helped reintegrate German medicine into the international community. Their influence on humanitarian medical organizations proved particularly significant. When Médecins Sans Frontières, Doctors Without Borders, was established in 1971, its founding principles explicitly echoed the battlefield medical neutrality these German doctors had experienced. 3 former Wehrmacht physicians with Allied collaboration experience served as advisors during MSF's formative period. Their first-hand understanding of how medical ethics could transcend conflict directly influenced the organization's core commitment to treating patients regardless of political affiliation. This philosophy, that medical need transcends national boundaries, represented the institutional embodiment of their personal transformation from nationalist military medicine to humanitarian medical practice. Reunions between German doctors and their former Allied colleagues occurred regularly over subsequent decades, often coinciding with medical conferences. Attendance records from a particularly significant 1975 symposium in Geneva showed 27 former Wehrmacht doctors and 34 former Allied medical officers who had worked together in mixed teams. The symposium's topic, Medical Ethics Under Extreme Conditions, directly connected their shared wartime experience to contemporary humanitarian challenges. Their panel discussions, preserved in audio recordings, reveal how battlefield collaboration had evolved into a shared professional identity transcending their former divisions. The transformation of these German military doctors, from indoctrinated Nazi military physicians to international advocates for humanitarian medical principles, represents one of World War II's most unexpected and significant legacies. Through direct professional collaboration rather than abstract re-education, through medical practice rather than political theory, they experienced the fundamental bankruptcy of nationalist medical ideology. The universality of human anatomy, the shared techniques of treatment, the common goal of preserving life regardless of uniform, these practical realities proved more powerful in transforming worldviews than any propaganda or punishment. Their journey from stunned disbelief when asked to treat enemy wounded to international leadership in medical ethics demonstrated how professional integrity could provide a path to moral reconstruction. The former enemies who became colleagues, the military doctors who became humanitarian advocates, carried forward a profound lesson: that medicine at its most fundamental level recognizes no national boundaries, only human need. This principle, first demonstrated in the bloody chaos of Normandy field hospitals when British soldiers asked captured German doctors to save enemy lives, ultimately helped rebuild not just bodies broken by war, but the ethical foundation of medicine itself after its darkest hour.